Hello, everyone, and thank you so much for joining us again for our COVID-19 chest webinar series. It is our honor and privilege to welcome three amazing panelists, and Sai, our guest of honor, is back. So I'm going to ask all of you to kindly introduce yourselves and also give us a glimpse into what it's been like taking care of COVID-19 patients at your respective care settings, and how did your facilities prepare for this? So Sheila, let's get started with you.
Hello, everybody. At the outset, I'd like to thank the organizers and CHEST for this opportunity to speak at this webinar. It's indeed a great honor and a pleasure to be here to share our experiences. So I'm Sheila Maitra, Professor of Critical Care, working at the Tata Memorial Hospital in Mumbai, India. I'm also the president of the All India Difficult Airway Association. I chair the the critical care section of the World Federation of Societies of Anesthesiologists. And I've recently been elected as the president-elect 2022 of the Indian Society of Critical Care Medicine. So that's just a bit of a background. Now, I work at the Tata Memorial Hospital, and some of you may know this hospital. It is one of Asia's largest cancer hospitals and one of the largest cancer hospitals in the world in terms of numbers. So for us, the pandemic has been really challenging because cancer, as you know, is a semi-emergency. And, we've been operating through the pandemic. Because the patient said it's okay if we can't have our surgeries delayed and we can't be dying of cancer. We don't mind getting COVID, but we can't be dying of cancer. So we had to continue to operate through the pandemic. So our operating rooms were running. And because of this, the surgical intensive care units were full, cancer therapies were on. So it was really challenging, striking this balance between, utilizing the critical care resources for cancer patients versus, doing this for the operating room. And we only looked after cancer patients who had COVID. Nevertheless, when the second wave, when the number of cases became very high, the municipal corporation actually requested us to look at even, into non-COVID patients. So in this sense, it's been really challenging, and there's a lot of experiences and learning between the first and second wave, which of course I'm sure we'll speak as we go along. So this is what I'd like to tell you about the unique aspects of our hospital.
Thank you, Sheila. And Deepak?
Thank you very much, Neha, for giving this opportunity and inviting me here. My name is Deepak Govil. I am working at Medanta, the Medicity. It's in Gurgaon, it's a suburb of Delhi. Not suburb, it's like a satellite town of NCR, Delhi in India. I'm working in a hospital which is a big hospital, close to 1,200 beds with around 300 critical care beds. I'm working there as a director of critical care. I'm looking after liver transplant, gastrointensive care, and thoracic intensive care. As far as the preparation is, like first wave came as a bang. That time nobody was that much prepared. Of course, we heard a lot of stories from the Italian colleagues and Chinese colleagues. So mentally, somewhat we were prepared. Our hospital was first hospital in India to have COVID patients in first wave, because if you remember, there were some Italian tourists who were the initial people who were diagnosed as COVID. They were shifted to our hospital. So one floor was converted to COVID area, and it was there. And then since April 2020, then the COVID patients started coming in. But that is an old story. Coming to the second wave, in January, February, we almost closed down the COVID thing. This year, hardly one intensive care unit was running with the COVID patients. And suddenly in the March, gush of patients started coming in. And within no time, in 2-3 days, we have to convert almost 200 beds of the critical care to the COVID ICUs. And it was really a tough task, because this time, many other patients were there in the hospital. So we have to occupy all the daycare, post-op, pre-op area, because surgeries were off. So we took over all the areas and converted them to the makeshift ICUs. And we shifted our routine patients in that area, because we don't want to shift. That time it was decided not to shift the COVID patients near the theater, because emergency surgeries were going on. So we thought that their AHU is common, so we should shift our normal non-COVID patients to that area. So that was there. And at the peak, we were having close to 170, 180 COVID patients in the all ICUs. And I remember one day that time, more than 100 patients were on ventilator, and we practically ran out of the ventilator. So we procured all the transport ventilators from our MRI, emergency, blah, 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 and we converted them to ICU ventilators. So
thank you,
that's it.
Deepak. What you're describing, both Sheila and Deepak, the challenges of taking care of patients with COVID-19 and the non-COVID-19 population. How do we continue providing the highest level of care for both of these patient populations? And the surprise first wave, and then how did India tackle its second wave? We'll do a deeper dive into it in just a moment. And Rahul, let's give you a few words in.
Yeah, hi everyone. Thank you so much, Neha and the team at CHEST for the kind invitation. It's a pleasure to be here and interact with everybody. I am the odd man out here. I'm an ENT surgeon in a crowd of critical care specialists. And the first wave had, very little contribution from our side in terms of tracheostomies for the sick patients. But it's the second wave which took us by surprise by seeing a lot of the invasive fungal sinusitis wave that we have seen, the mucormycosis wave that we have seen. I work in a suburb of Mumbai in two tertiary care hospitals, Hirandani Hospital and Holy Spirit Hospital. Both have been at the forefront of COVID. And I think in combined over the last year and a half, these hospitals have seen close to 15,000 COVID patients of all severities. So they have been at the start of the pandemic, right before the first lockdown. They had the systems in place, they had the team in place. So managing COVID patients was a primacy. We were literally out of work during the first wave, so to say, because the entire hospital was taken over. But the second wave is something that unfortunately we got to see a lot of the complications of COVID, so to say. And the mucormycosis was a real surprise. The sheer
Rahul, I think we just lost your audio a little bit.
Yeah, so I was saying that that the mucormycosis wave actually caught us by surprise when we were just seeing these patients of something of a rare condition, which we were seeing almost 100x of what we were seeing, say, in the pre-COVID era. So I'll be happy to share my experience with mucormycosis when the time comes. Looking forward to the discussions.
Thank you so much. And all three of you have described very, in some ways, similar care settings. They're large, they're taking care of a lot of patients, they're on the front lines. With respect to the Indian healthcare setting, there are a lot of different ways in which we're delivering care in India. Would love to hear from all three of you about the different healthcare settings and what challenges do these different healthcare settings pose, and the sort of rural-urban divide. Does it make it challenging? Does it make it any easier when you're tackling a pandemic like COVID-19? So Sheila, let's start with you.
Right. Very important question you raised, Neha. As you are aware, there's a wide variation in clinical practice across the country. And you have some of the best of setups and private setups, like where Dr. Govil works. You have government institutions, and you have very small facilities. So the care really varies depending upon where you're being treated. And this is a challenge. And the biggest challenge really for India, and what we were really afraid of, was the infrastructure, not only in terms of equipment, but also manpower. Though we are a very big country and we have a large number of doctors and nurses, when you look at it per 1,000 population, the numbers are really minuscule. So the biggest fear actually when we saw this happening in China and Italy was that, how are we going to ramp up for this situation? Firstly, being unaware of the disease itself and how it's going to pan out, but not being able to. So this was a big concern about the resource, the resource crunch that we are facing, and how would we manage this? We have such few ventilators, the nurses, the doctors. So in the beginning of the pandemic, one of the best things that happened, I think, was the lockdown, though it was quite political, because we had our cases actually started to rise after 15th of May. So we had 2 months to prepare. It was one of the biggest lockdowns in the history of the planet. I mean, locking down 1.35 billion people was not a joke, but it was a very strict lockdown. And I think that served us very well, because what we did in 2 months we were observing what was happening in the West. We were seeing what was happening in Italy, in UK, and we were sharing our experiences and trying to learn from them. And then we were trying to ramp up our infrastructure. Every hospital was advised to double their beds, make private facilities. Even things like personal protective equipment was in great shortage. Testing was only available in certain labs. So I think we utilized this 2 months really well and also prevented the spread. So I think in the first wave, honestly, despite having very limited resources, we kind of, learned from the experiences, and we kind of got around with, managing reasonably well. We didn't have that kind of situation that we had in the second wave, which of course we'll talk about. So this was the challenge in the beginning, was not knowing much about the disease, and also the limited infrastructure, which the 2 months gave us good time to prepare.
And Deepa?
So I second majority of the things what Sheila said. I just wanted to add about, you talk about the rural and urban divide. So it is not that rural and urban divide exists. It is also there in the metropole cities. Like if you go to one particular area, it has got very shabby type of old nursing homes. And in a particular area, there is a plush hospital, which one can compare with any Western facility. So that divide exists everywhere, not only in the rural and urban. But the thing is, in the first wave, everybody was there and nobody knew what to do. What happened in the second wave? The number of patients rose suddenly, so many, that it was difficult to manage at that point of time. I remember when in the first wave, we started opening ICUs gradually, but in second wave, I was like, we were running 2 ICUs, 44 beds of COVID patients, and suddenly in the morning there were 20 patients in the ER, and ER was calling frantically, and we thought that we'll open another ICU. We shifted patients in 2 hours, and by 11 we were ready to take patients, and believe me, by evening all 22 beds were full. So in the night we emptied another ICU and converted it to COVID. So second wave was much more challenging, and people were, with the social media, people were aware about it. So many more patients came to ICUs and came to hospital, and there were many patients, people who were not actually deserving the hospital care, but they, out of fear, out of whatever you can say, because they can afford the hospital, they landed up in the hospital, and they started calling frantically through any known person or from politicians, from bureaucrats, that give a bed, give a bed. So that was another challenge. Then there was a resource crunch. Suddenly, you imagine if an ICU is having all the ICUs were designed, like in my hospital, we have got close to 160 ventilators, but rarely they work together. Just imagine now every 300 patients are on oxygen therapy with HFNC, NIV, ventilators, all running with 100% FiO2. So just imagine what is going to happen with the oxygen. So that was another challenge. That's it.
Great. So I'm just going to jump in and ask Sheila a difficult question because she likes difficult airways. I'm just kidding. But I'm just going to, so I do critical care for India and the US. I do remote intensive care. And one of the things I have noticed is that airway management is key to the COVID pandemic in terms of saving lives. So Sheila, I've heard some of your lectures. I mean, you have amazing insight into the airway management, the complete pathway that's involved. So what do you think would be like 3 top things that we should follow in terms of airway management in a COVID patient? And is there any way that this can be taught to people who are not intensivists or not anesthesiologists, but who are plain either basic medical degree doctors? Can you teach this to them, and how long would it take? Because it's just a 2-part question. Your tips for airway management, and what do you think would be a quick way to teach them if another pandemic comes through?
Right. I think this is a very relevant question. COVID being primarily a respiratory disease, the airway management is really the key. And this has been very challenging because all along when we did airway management, we were only concerned about patient safety. For the first time, we had to also think about the healthcare worker safety. And tracheal intubation being an aerosol generating procedure, I mean, we really had to think about how are you going to protect the healthcare worker and the, keep the patient safe. So this became like a big challenge. And as president of the All India Difficult Airway Association, I mean, we really had to very quickly come up with guidelines as to how we would, handle the airway safely and keep the airway manager safe. So the thing that was paramount is to optimize first pass intubation success. So you can shorten the time so that the exposure is also less and also reduce the complications. And, to do this, you have to have an experienced airway operator. So you cannot get the most experienced one at any time in the day or night, but whoever in your team is the most experienced operator should be the one intubating. It should not be just anyone. And the other thing is that when you use video laryngoscopes, and this is one area where video laryngoscopes really score above direct laryngoscopes, because you don't have to look into the oral cavity, go close to the oral cavity, and you can actually be looking at the screen. In addition, video laryngoscopy also has a higher chance of first pass success. So these were two kind of interventions that were really, really helpful. Of course, you may have heard about the intubation boxes that were initially being used. And it all started with, I can understand that it started with good intentions because people were, concerned about protecting the airway operator. And in a country like India, where manufacture is cheap and there's all kinds of innovation, we had all kinds of boxes and people trying to, hole here, for getting their hands in. This made intubation difficult. This increased the time. This, PPV used to tear. And I was so happy when we finally had evidence to show that these boxes actually cause harm. And when you remove the boxes, it actually exposes the operator to a higher concentration of the aerosol. There was so much discussion on the intubation boxes, on social media. It actually became more viral than the virus itself. So initially we were using it, but then now in the second wave, we completely did away with it. And I would say you need to limit the number of people who are around. Sometimes when you have a challenging intubation, especially like this in a COVID patient, you may want to have a few more operators, but you have to limit the number of operators to one or maximum two because you want to expose less of your staff. Now, a negative pressure isolation, I mean, it's not feasible, but a lot of units were doing the intubation in, for example, if you had one negative pressure room, you would intubate the patient there and then transport to the other room. But this is not feasible and not practical. And as we went along the pandemic, we realized that more than any of this, it is your personal protective equipment that is going to safeguard you. And you should do your usual practices with airway management to ensure patient safety. So rather than avoid, like we were not using high flow, we were not using NIV, we were not doing these things in the beginning of the pandemic, we were intubating patients very early. So all these practices really completely changed over time. So I would say with airway management, video laryngoscope, and having the most experienced operator in your team. Regarding training, I would say, at times like these, when we have lesser number of cases, simulation-based training is very helpful. Training people with mannequins. It's difficult to make people experts in airway management overnight and tracheal intubation, but definitely they could assist. They could be the runners. They could be, so these kind of things, definitely not only ICU staff and ED staff, but also other specialities could help in this process. So I think all this should be done at a time when you have fewer cases. And simulation-based training in airway management is definitely the way forward.
Sheila, both and Deepak have touched upon so many important themes around resource management. Resource management, both the equipment, the beds, the way we organize care, and the way we're training people who are not just intimately associated or taking care of critically ill patients, but also how do we prepare people to do this in a safe manner, protecting the healthcare worker, particularly in the midst of a pandemic. We can't even imagine how hard it must have been to ramp up some of these resources, particularly given that some of the settings were already resource limited, like Deepak highlighted. And that's been a theme for the US, that's been a theme for several parts of the world. And despite us being aware of these healthcare disparities before the pandemic, I think it's really shining a massive light on these healthcare disparities, which have just been magnified by the pandemic. Sai, you have some great experience with tele-ICU resources. Would love to hear some comments from you about how tele-ICU resources were ramped up for COVID-19 in India and beyond.
Sure. Thanks, Neha. So I work at Apollo Hospitals, and I also do remote intensive care for India and one for the US. And what we realized is, I was doing night shifts for the US, and it was exceedingly busy. Imagine managing 120 ARDS patients. It was very busy, and you had to just do stuff, and you can't really take any shortcuts because these are young people, and unfortunately, it's happening again now. The unvaccinated young people are, and some older people are again having a very bad lung disease in the US right now. But I think one of the things I've realized is that the resources in India, especially, you have plenty of doctors. In other countries, you have plenty of nurses who are very well trained. You have plenty of respiratory therapists. But in India, you don't have that many respiratory therapists at all. You don't have that many nurses who can do critical care. But I think, kudos to ICCM for really training and ramping up people in both of those areas. What I've realized is that if we can actually do quick training, and we were able to do ventilator training through my hospital, we were able to do a lot of webinars as well as direct hands-on experience with troubleshooting ventilators, troubleshooting ventilator alarms, to avoid transfers of patients. So this, the rural patient who gets in an ambulance is almost certainly going to die. So kind of they avoid using remote care. And actually ask you, you at Mount Sinai, right? What was it like New York in the first wave? Was it anything like what we saw in India? Do you remember any of that anymore?
Absolutely. We ran the second COVID ICU at Mount Sinai, and a lot of the things that both Deepak and Sheila were describing, quickly ramping things up, converting ICUs to COVID ICUs. In some ways, I do feel very grateful that I was at a health system that had access to a lot of resources. We were able to convert all of our ICU rooms into negative pressure rooms. So even during the first wave, when we didn't know a lot about this disease process and aerosolization and how much we need to protect the healthcare worker as well, what kind of PPE do we need? At no point in time did several of us feel like we were not going to have enough. While there was all this modeling that was very scary, particularly during the first wave, when New York became the epicenter, I think we were very fortunate. And for a lot of our colleagues, even across the US, particularly after the first wave that we experienced, it was rough. It was exactly as you described, with this constant fear that you're going to run out of resources and people who are trained to be able to provide the kind of care that needs to be provided.
Sure. I'm going to direct a quick question to Dr. Govil and Sheila and to Rahul. How do we avoid subglottic stenosis? What are the practical tips in terms of two things we should do when we are using those endotracheal tubes? Because Rahul, I'm sure you're starting to see some of those now.
So we are seeing more in prolonged intubation. So in patients in which we expect, a stormy course, a prolonged course, I think early tracheostomy has always been the gold standard to avoid that subglottic stenosis. Apart from that, I think smaller size tubes and monitoring cuff pressures and maintaining good oral hygiene, which have been the traditional ways of preventing subglottic stenosis. But in the pandemic, with the healthcare resource personnel, the ICU personnel being overwhelmed, it has always been a challenge. So, fortunately at our institutes, the place that I am practicing, we have kept a very low threshold, in fact, to do an early tracheostomy. So we are not seeing that many subglottic stenosis, but we have seen a couple of them who are managed elsewhere, and there was a delay in tracheostomy, but none of them were very severe, and they're just recovering now. So just with conservative management, we are planning to, treat them.
I'd just like to add, if I may, so this was, though I just saw one or two cases, this was a concern in some areas. One of the reasons was because of the very early intubations, especially in the beginning of the pandemic. Because, at that time, we really didn't understand the disease, and people would see a patient with, low P2F ratio, these very scary CT scans. And, later we started going purely clinically. If there wasn't increased work of breathing, there weren't signs of respiratory distress, we would allow them to, the so-called happy hypoxics. We would just not intubate them. But in the beginning of the pandemic, we were intubating them very early. And the other concern was about extubating. So people weren't extubating early because they were worried that if I extubate too early, then again re-intubation will again expose the healthcare worker. So a lot of extubations were also delayed. So like Rahul rightly said, there was a lot of prolonged period of tracheal intubation, cuff size, and a lot of units, because of the manpower constraints, were not able to do cuff pressure monitoring, and all the routine things that we do, airway management really went for a toss. Then even the timing of tracheostomy was debated. And there was a Delphi on that. And then, so these kind of things definitely led to prolonged intubation. So I think now, with a better understanding, we are intubating patients not early, not late, but at the right time, I would say. And we are not worried about extubating patients, because we are transitioning high-risk patients to using high-flow nasal cannula oxygen, or extubating them on NIV, which we weren't doing early in the pandemic when we weren't using these two therapies. So I think this has definitely shortened the duration of tracheal intubation. And also concerns about tubes. Some people were putting larger size tubes, because they were a little concerned that, there shouldn't be any leaks, and, concerns like this. I mean, I just saw some people talking about this. But so these kind of things may have definitely led to a higher incidence of tracheal stenosis.
Of course, earlier in the pandemic, a lot of misinformation, a lot of fear, and that fear getting channeled into deviating us from practices that have been well established, evidence-based for ARDS from non-COVID-19 viruses and instances. But overall, all three of you in some ways have alluded to information management and how social media, and how do we ensure that in the midst of a pandemic, for a country as massive as India, how do we ensure that there isn't this propagation of misinformation, and timely information is available to people to make the right decisions at the right time?
Sheila, would you like to start?
Okay, so I think social media can be both, beneficial, as well as it can be very dangerous. I can tell you that I read many things on social media, and it really helped me. But on the other side, like you're saying, there was a lot of propagation of misinformation. So one thing for India, especially with technology, I think all of us learned how to use Zoom and learned to use these platforms. So communication became much, much easier. And I think societies like the Indian Society of Critical Care Medicine and other societies, took the lead in, generating guidelines, disseminating information. So I think as long as people, reach out to authorized, associations or bodies to get this information, it's fine. You can have no control on this WhatsApp University and this kind of misinformation. So I really would leave it to the individual, but I think they should go to authorized sites, like the national sites that we have in the government sites, and also the, the associations, so that they are sure that the information that they're getting is, been vetted through people and is reliable.
So can I say something? So the social media played very important role, but side by side, as Dr. Sheila has highlighted, it was a misinformation campaign as well. I can just recount one thing, that in the previous first wave, I used to receive calls from different people, maybe doctor, paramedical, patient's relative, that do you have a ventilator available in your hospital? And in the second wave, things reversed. And people started asking, do you have ECMO available? How can we procure ECMO? Few people even offered to buy the ECMO, offered to rent the ECMO. They started asking the company's name, that from where we can buy the ECMO machine. And few people started calling like a call center. So they probably there were some NGOs or young enthusiastic boys and girls who started calling like a call center, that I'm calling from X place. We have got one patient. Do you have ECMO bed available? And they were not even ready to listen that ECMO bed is not so small thing. Like we have to first evaluate the patient, whether the patient is for ECMO or not. And later on, I realized that many patients were not even intubated and they were asking for ECMO beds. So this was the ugly face of misinformation there.
One of the challenges, if I may just interject, that we faced is in the first wave, so to say, we had probably lesser number of patients and lesser doctors involved in the care. when the second wave came in, we have doctors from all specialities and doctors from all, I would say, even alternate medicine joining us, and that added a little bit to the confusion. So the thing that we probably should take as a message as a community treating patients is to try and adhere to guidelines as much as possible, and not so much as to whatever works for me kind of a culture. So that was an important message for everybody, that the state governments, the national government was coming out with guidelines, but there was very high level of reluctance initially to follow them, and then there was good adherence to that.
Thanks, Rahul. So I think, I'm just going to preface this next statement with a little bit of a plug for CHEST. And, CHEST has been doing these webinars. They're a global organization. They've been talking about education, etc. If you go to their website, they have an entire COVID section. And they started pretty early. And people like Neha and her team, the digital people, they've been actually updating it very regularly. In India, each of our hospitals has done. For example, my hospital, we have the 45th edition of our COVID guidelines for the whole country, which we use. So there's been a lot of good work. But I'm going to ask Deepak this question, because you guys have done an amazing job through ICCM, through the journal, through your website, and all the different protocols and committees you've instituted. I'm not going to ask you about those specifically, but Deepak, what drove you to get there? Because this is very forward thinking, and you guys jumped on the what needs to be done very quickly in the pandemic. What do you think drove you to do that?
It was the need of time, and it is not everybody was of the same opinion that society should come forward and do whatever they can do. And I'm quite happy and I'm very lucky to have a group of dedicated doctors, people like Sheila and others who are with us here today. And everybody, despite of being too busy in the patient care, took out the time to come up all these things. So there were many policies and guidelines or position papers published in our website. We did regular webinars. Last year, we conducted so many training sessions for paramedics, non-medics, and especially the non-intensivist, along with the Indian Medical Association local branches. So we conducted more than 25 webinars in different areas of India. And we prepared few modules of oxygen therapy, ventilation. That was jointly, Dr. Sai was also part of that modules. He took his time off and recorded his lecture and was part of that team also. So we did so many things, and believe me, it was not a single person who did it. It was the whole society, whole executive committee, whole like-minded people, all the intelligentsia. They suddenly came together. We don't have to call anybody. People used to call us that why you are not doing this, I can do this. So whenever I get a call, we always say, if you can do this, please go ahead. Please go ahead. So it was a enthusiasm and dedication of all the members, not a single person, I would say.
That's very great. And Sheila, I think you're going to be carrying this forward to the coming year, right?
I hope so. So I'd just like to add, I think one of the positives, like they say, every cloud has a silver lining. One of the positives is that COVID has really been a unifying experience. It's kind of, especially in India, and I'm sure globally as well, because it's got a lot of people and, together, and a disease we don't really know too much about. Let's share our experiences. Let's learn from each other. That kind of feeling. And though it's unfortunate today we are, online and we can't be physically meeting, I've met up with more people online globally than I would have ever imagined. So I think webinars like this, organized by CHEST, where we can share our experiences, learn from each other, and also, share data. And also, I have been able to, really collaborate with people and do global publications on COVID, which I haven't been able to do before COVID. I mean, I didn't have to wait for COVID for this to happen, but because of, being able to meet people online and not having to travel and spend money and have meetings physically, has been actually one of the positives, because without spending much money, we've had exchange of knowledge and also education, because I think these kind of webinars where you learn from each other's experiences and you share, you have educational material put out, I think this is really useful. And I wouldn't say just for the pandemic, but I would say this is something that we should carry forward even when there isn't a pandemic. so that, we can have these kind of webinars, and we know this is feasible, and more people are now tuned to this kind of, online meetings.
Yeah, absolutely. And I think I'm just going to segue right into the next kind of theme that actually been getting some audience questions about this. What does India need to do in terms of infrastructure, in terms of training? What kind of upgrades do we need to do to our healthcare? So if you had a wish list to say, in the next 30 days, you can do what you want to India's healthcare, what would you want to do?
Wish list is a very long wish list. It is difficult to, it will take hours to do. But of course, the biggest wish list is to train our junior doctors, train our colleagues, and not only that, train our paramedics, because nothing can happen without paramedics. And this pandemic has shown us that we are nothing without our paramedic support, without our junior doctor support, because nobody, single person cannot do anything. Though gone those days where there used to be a professor or boss used to take a round in the ICU and 10 people are following him and he is barking orders and everybody is following. We find that it's impossible in the pandemic days. So unless we train our paramedics, unless we train our junior doctors, nothing can happen. That is the topmost list in my wish list. Of course, there are so many other things, the infrastructure, the reaching out to the rural area, blah, 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 so many things. But if you have asked two things, I'd say the first thing is to train our paramedics and train our junior doctors.
I'd just like to add over here, and one thing that COVID taught me, I saw the best healthcare systems across the globe in the most developed countries collapse during COVID. And this made me realize that no matter what infrastructure you have, how many beds you have, how many doctors, you have to prevent the disease in the community. If you have this big wave coming into the hospital, no matter how well you've equipped, you've already lost the battle. So I think it's very important first for public health measures to be reinforced and prevent this from coming, because once the patients have started coming to the ICU, and this especially we noticed in the second wave. So I think we have to prevent this first. And this is where governments, healthcare organizations, and all have to play a key role, rather than say, okay, now the patients are coming, ramp up your facility. How much are you going to ramp up? Why did the most developed world with the maximum number of ventilators also collapse? Is because no healthcare infrastructure can handle this kind of situation when you have such a surge. But having said this, I feel definitely one important area, we can't just expect doctors and nurses and intensivists alone to do all this. What we have to do is we have to use all the other specialities. And during times when there's a lull, we have to really train, like Dr. Deepak rightly said, even paramedical staff. We had surgeons on board, we have physicians on board. So you can train them for certain activities where you can help you. And the third very important message I want to give is don't lose your guard. Because I think in the second wave, we suffered because we were very complacent. What happened in India is, unlike in the other countries, we had a very long first wave. People were completely, exhausted. We started in May and then till December, this went on. And finally in Jan, when the cases were almost negligible, we felt, look, we were a country with limited infrastructure, less resources, and we managed so well and our mortality wasn't too high. So we became very complacent, and when the vaccines came in January, mid-January, there was a lot of vaccine hesitancy because people thought a second wave would not come. So I think the biggest mistake we made is losing our guard. And the second wave, of course, it was also variant dependent, but the sudden surge, like Deepak described, in 2-3 days, and 10 times more the requirement of oxygen and all this was something we just couldn't handle. So while we do need to improve our infrastructure, both in terms of manpower as well as material, I feel the most important thing is to prevent this in the community and not let it come into the hospital.
Absolutely.
Really important points, right, Sai? These are,
absolutely.
Despite you describing this for the Indian context, it is so applicable to every country in the world, irrespective of what types of resources we have. And not forgetting the lessons we've learned in the midst of the pandemic. The investment in public health, particularly for developed nations like the US, we haven't been paying as much attention to public health simply because prevention is so much harder to do than when you're in the midst of a crisis, let's buckle down and take care of the crisis. But what do we do to create sustainable solutions so that we don't run back into this, some of the the preventable mortality that we all ran into, and how do we prepare for the next pandemic, right? Sai and Rahul, this is probably one of the biggest challenges for us. While you're in the midst of a crisis, how do you prepare for the next crisis? Because this is not going to be the last pandemic of our lifetime. So, Rahul, quick segue to you about the second wave. We heard from Sheila some of the potential missteps that India made for the second wave, and you saw this big surge of mucormycosis and destructive sinusitis. So comments about that. Was this preventable, and what can be done about it?
So surprisingly, just a quick observation, the hospitals, and there is actually some published data to back this up also. So none of the so-called tertiary care hospitals that are there, kind of like, in my knowledge, so close to managing about 25,000 patients of all severities, we didn't get a single mucormycosis patient in-house. Okay, so most of the patients that we saw were treated in sort of a resource-constrained setting where you would expect the personal, the doctor-patient ratio, the nurse-patient ratio, to be not to the greatest, not to the best levels. So I strongly feel a large number of, if not all, a large number of these mucormycosis patients were perhaps preventable because initially there was a lot of hesitancy in the first wave in using the glucocorticoids or the steroids per se, and they came in a little late in the wave. And but in the second wave, it was, everybody was on steroids. I mean, whether it was a young individual who was not even requiring oxygen, was treated at home, was also prescribed steroids. And then in other settings, it was very difficult for them to monitor sugar, perhaps. So I think the biggest lessons for us is not to forget our basics, not to forget the basics of management, and to ensure that, we are able to maintain a basic level of care to prevent this from happening. So that's the basic question. And, mucormycosis has been a challenge as to, is it only the steroids? There was a lot of myth in social media about, the industrial oxygen use causing the mucormycosis spread. And there was no data to back this up. And even till today, and everybody was blaming, the COVID Delta variant to cause some special changes in the body's immunity. Yes, COVID-induced immune dysregulation is kind of documented. But all these major centers in Mumbai, which had, huge thousands of patients admitted, they had the same COVID variant and they were able to escape the mucormycosis. And I think mucormycosis was just one of the list of the many secondary infections that happened to our COVID patients. So to the same, good care, just basic good sugar monitoring, and just making the patient aware, of the early signs and symptoms could have prevented the sheer scale of it. And that is where the rural and the urban divide came in. Patient centers which had a lot of rural drainage had the maximum impact. You talk about Nagpur, you talk about Pune, you talk about Jaipur. These centers, Aurangabad, these had the maximum number of mucormycosis patients compared to the patients that were there in Mumbai and how many mucormycosis cases were there. So that's my take on it.
I just
Thanks,
want to add
Rahul. Go ahead,
about coming from a cancer center. So when we saw this kind of mucormycosis epidemic kind of happening, we'd seen cases of mucormycosis, but not like this. And we didn't have a single case in our hospital. So I really strongly believe it is dependent on the usage of steroids, the dose of steroids, and other immunosuppressant therapies. Because people were so worried about not getting an ICU bed or going on oxygen, they were actually using steroids to prevent, getting into hospitals. People were taking steroids at home. So there was a lot of indiscriminate use of steroids, and I think this may have largely contributed. But institutes where the sugars were tightly monitored and also the steroid, there was control on how much dose as well as the indication for giving steroids, they didn't really see much mucormycosis. So there was a wide variation in the distribution, though the number of cases were high and the government actually declared it as an epidemic.
Thank you, Sheila and Rahul. If we really look back, this is the war of our generation. We hear about the world wars, but this is what it is. And the innovation that's come out, the compassion that's come out, these are all things which will stick with us for the rest of our lives. And I'm so privileged and thank Neha and Chest for this opportunity to meet leaders like yourself, Sheila, Deepak, and Rahul, to really share your insights, because it's very important for an entire generation that's following us, looking up at you as teachers and leaders, to really follow in your footsteps. And while they do follow in your footsteps, many of them are staying up at night, they're working long hours, and they are exhausted. I'm sure you're all exhausted. And I think this burnout concept is, we are doctors, we don't burn out, but we do. And I'm just going to ask each of you for one point as to, how do you avoid burnout? But we're running at, right at 45 minutes. It's like a good Netflix episode is gone through, and we're at 45 minutes, and we have just a little bit of time left. But if you can just tell us, what would you think we should do to avoid burnout? And right after that, I'm going to ask you a much more, important question on the ethics of care. How do we deal with it? These are tough questions which don't have answers, but how do we actually do that? So I'm going to start with Sheila, if you want to go ahead and tell us, how do you deal with burnout?
So, this is a very, very important topic that you've raised, and something that was very, very neglected through the pandemic, because we were just so busy, trying to figure out what treatments to do and manage our infrastructure and resources that, thinking about burnout or dealing with burnout was very, very far from our mind. And in India, it was specifically, it was very relevant because we had a very long first wave. We didn't have even a summer holiday. People were not going on leave. The other very challenging thing was that we didn't have families coming into the intensive care unit because of limited PPE and also concerns about infecting the relatives, etc. So doctors were watching patients dying in isolation. They were watching, having to deal with the various aspects that the family was involved with the patient and, talking to them. And the patients were seeing these doctors who all looked alike. And it was absolutely, not a humane kind of environment. And also this fear of getting infected was making doctors, spend very minimal time with the patient. So this whole experience, and also doing extra duties, extra shifts, many colleagues turning positive. So, we were not able to give leave for people. And also in India, not so much of psychological support for the doctors within all the hospitals or the time for this. So all this resulted in significant amount of burnout. And I noticed this later when we started talking to our residents and our trainees, etc., that, there are, and now we have a lot of published literature on this, even internationally, about the burnout issues in the ICU. So I think, though it's not possible to provide so much of psychological support and have this all available overnight, definitely within departments, leadership should take the role of talking to your colleagues. Talk to them, assign somebody who can, talk to the residents, to the trainees about their well-being. Are you okay? Have you had enough sleep? Have you had enough rest? And however possible, what we've started doing is to give people some breaks, try to work it out in such a way that the work doesn't suffer, but give some time off to, different trainees for a few days so that it'll help them rejuvenate. So various things can be worked out, but definitely trying to make, psychological support available for the staff would be a long-term goal. That is really been an eye-opener with COVID, that this is something we really need, because we need to take care of ourselves also, because a human resource is one of the most valuable resources for any healthcare system. So if you're not only the physical health, but also the mental health. So this got highlighted, I think, more in COVID, and we realized the importance of this in India.
Sheila, very
Absolutely.
well said. And incidentally, Chest's next webinar on September 30th is going to be about building a community of getting well together. And this is not going to be recorded. These are going to be Zoom breakout rooms. We're going to facilitate some discussion around unpacking, processing some of the loss, the grieving, the rush of emotions that all of us had to deal with in the midst of all these various waves, or this ongoing massive wave of the pandemic. We're still not in a post-pandemic world, but making sure that all of our organizations across the world are collaborating to establish some firm guidance on what needs to be done to support one another, not just in the midst of a crisis, but building that community irrespective of whether we're in the midst of a crisis or not, so that we can come out stronger at the end of a crisis. the ethical question that Sai was posing. We had a lot of talk about we'll run out of ventilators and then what are we going to do, rationing of care. Rahul, Deepak, Sheila, how did you deal with that? And was that a concern?
Yeah, sometimes it was a concern. To me, it was a concern not for ventilator, not for ICU bed. Sometimes, like in second wave, it was a concern for ICU bed. I couldn't like entertain all the calls which I got, and even few of my relatives, friends, doctors, even my colleagues' family, I had to say no to them because we were not having beds. And the second ethical dilemma was putting ECMO. That was biggest challenge of the life, and believe me, it was so difficult to judge whom to put, whom not to put. There are 5 or 6 young guys all requiring ECMO, and we don't have got ECMO. All the ECMOs are running. So that was biggest challenge. It was sometimes very frustrating, very difficult to deal with. And I remember few of our junior doctors started crying even to do what we can. Few suggested that we should take out ECMO from this patient and put in this patient. This is having least chances of survival. I know people started saying that I know in 2 days he's going to die. Why don't you take out ECMO from this patient and put on another patient? But that thing cannot be done, and never we did. But again, it was a very difficult situation to see people are dying.
Thank you for sharing that, Deepak. It is that tremendous amount of moral injury that comes with having to even think through some of these questions, whether we have to act on those or not. Even the process of going through the thinking of we may need to do this is very, very hard. And I'm hoping that organizations like the Indian Society of Critical Care Medicine, CHEST, SCCM, ATS, ESICM, and several organizations are going to bond together to help us unpack and process what has happened, so that we don't break down, that we as a healthcare community just come out stronger. I know we're coming up towards the end of our webinar. We have our last few minutes left, and we are going to count on all of you for your final words of wisdom and takeaways for the future. How do we become stronger and prepare well for the next pandemic? So let's start with you, Rahul. Final words.
So my learning from the 2 waves was better communication between the team members. What is that person looking for? What is my role? And, to help out as much as I can to be supportive to the team leader. So again, I would go with better communication and keep an eye for, abnormal presentations, so to say. Just keep an eye wider. I mean, I am thinking after the mucor wave, if the person is post-COVID, has had moderate to a severe course, if he comes with sinusitis symptoms, I'm thinking of mucor now. So keep an eye for abnormal presentations. Things will surprise you, and be on guard and communicate well. That would be my kind of message to everybody.
I would second that. I would say that definitely don't lose your guard. That's what the second wave has taught us. But some things that I learned, especially during the second wave, and I felt also through the pandemic, is one of the biggest challenges we faced was communication. Communication with patients and communication with their families really suffered. And I feel in future, we should have, with all this technology, we should have better mechanisms where patients and, relatives, can communicate with their families. Because I watched so many patients dying in isolation, and that was a very, it was very disturbing. So I thought we could have done better with communication, even for remote monitoring. We couldn't have so many people going into the unit, but we should have had better facilities like Dr. Sai has highlighted. So these are the areas I feel we can really come up, with. And the other thing which we were not very well trained for is to cope with surge capacity, and also interdisciplinary kind of communication and dialogue, because we are in these silos. And I think that's where we have to kind of, have this team building and, hope for the best, of course, but prepare for the worst. On a medical front, from this, right from the beginning, where people were debating whether this is an ARDS or not an ARDS. Steroids, which we're not routinely using for ARDS, tocilizumab, monoclonal antibodies, these showed promising results in COVID-19 related acute respiratory failure. So perhaps these therapies need to be, reevaluated or reassessed in non-COVID ARDS. So this is something that has made me really wonder, perhaps there's a role for steroids. So on a medical, for medical management front, definitely. But otherwise, I would say communication and preparing for surge capacity and interdisciplinary communication.
And Deepak?
Yeah, I second what Rahul and Sheila has said. I don't think so. There is much to add it. The only thing is that a collaborative theme is needed to how to deal with this. We should have a long-term planning, not a short-term lookout. And these pandemics will come back again. Nobody knows when they will come back again. Maybe a year, 2 year, 5 year, 10 year. The moment we lose the guard, they will be there. So we have to prepare for them. And it is very difficult to prepare for an unseen thing. You can prepare for a thing which you know that is coming, but it's very difficult. It's very easy to say that we have to prepare, but it is very difficult to prepare because how much resources can anybody mobilize? Even the Western world, they almost failed. Whatever I say, they failed miserably to cater all their population because all the hospitals, any facility you create is created on the basis of some data, the percentage of the people, how many people are going ill every year or something like that. Suddenly then the 10 times patients started coming, it is very difficult. One thing which I can foresee or I can think, you can say it's out of box thinking, that like we have a reserve army, we do a practical training of army to people, and after short service, they go back to their civilian life and start working there as a civilian person. And whenever there is a need, army can call back them again. If we can have that type of force, especially for paramedics, that may help in the next pandemic. I don't know whether it's doable or not.
I think that's a great idea, Dr. Deepak. And I'm just going to, we've got just a couple of minutes left. I'm just going to close with this quotation someone told me. Every day you're learning more, you just have to keep learning more. There's just things you're learning more every day. And even 100-year-old lives only for 36,500 days. Time is limited. So we really need to do our best to deliver care for pretty much everybody who needs it. And innovation, technology, science, all of this has to come together so people who don't have care can actually get it. And these kinds of conversations, we've talked about the theory of science, the theory of airways, we've talked about the pathology of the disease, we've talked about compassion and ethics. It's a beautiful discussion we've had today, and I really appreciate all of you taking your time. I do need a better mask, though. I'm really wondering why hasn't anyone innovated that better N95 mask? So with that, I'm going to give it to Neha. And thank you, Neha, for a wonderful job at coordinating this beautiful webinar.
Thank you so much, everyone, for being so generous with your advice, with your time, with sharing your perspectives, right from science to compassion to ethics, as Sai mentioned. Some of the themes that were all prevalent in all of your responses was this need for fluid collaboration across countries, the need to work together so we can learn from each other's strengths and be able to counter each other's weaknesses. And it took Sheila, you mentioned for research, these international collaborations, these artificial boundaries that we had for data sharing and for creating large registries, those were all broken down during COVID-19. So I'm hoping that some of these lessons that we have all learned about collaboration, about working together, about helping each other out in crisis, about understanding our healthcare disparities so that we create safety nets for people who are going to be more vulnerable when our next pandemic arrives. It's just a matter of time, and preparing, like Deepak said, preparing for something that we don't know is so much harder. But some of the principles that we have learned, those are lifelong principles that we should not forget. So grateful for everything that you have shared today, and we'll be posting our recording soon to our audience. Thank you so much for being so engaged and posing all your questions. For those of you who missed out, worry not, we have our repository of all of our webinars on CHESS website, so please do access those resources. Thank you so much. Have a wonderful day.
Thank you very much.